Good afternoon, participants. On the behalf of the Academy of Medical Excellence, I welcome you all to today's webinar on antipyretics and fever management in children. I'm Dr. Pankaj Tikku. I'm your moderator, and I thank Apex Laboratories for supporting this event through an educational grant. So today we have two presentations lined up. So the webinar will have two presentations. The first presentation will be on current antipyretics and their safety in children. We have with us Dr. Kiya Ghosh Uttam, a very well-known pediatrician from Kolkata, and she'll be talking and sharing her views on this topic. So over to you, Dr. Kiya. You can start the presentation.
So good afternoon, everybody. So this is basically we will speak on this main purpose of this webinar is to discuss the current antipyretics and their safety in children. So now fever is a very important clinical manifestations, and most of the practitioners, the pediatricians, be it physician, be it practitioners, the main important presenting features with which the patient comes to them is fever. So it is a temporary increase in normal body temperature, typically in response to any underlying illness or infection. Most pediatricians consider the temperature above 100.4, that is 38 degrees, as a sign of a fever. You have to remember, fever itself is not a disease. It's just a manifestation. It's rather a symptom of an underlying condition. And why this fever occurs? Whenever some infectious etiology or any inflammatory etiology, may not be any infections. Whenever there is a chemical mediators due to fighting for this pathogens or due to some inflammatory conditions, some chemical mediators are liberated inside the body and they reset the thermostat of our brain. So the thermostat in the brain is reset. Suppose we are supposed to maintain a temperature of 98.4. And this, by this chemical mediators, the thermostat gets resetted, like in an air condition, we reset the temperature. It's being reset at maybe at 102, maybe at 101. And the body does everything to go to that temperature. Okay, so often you will see fever coming with a viral infection, also coming with a fever of 104, 105 degrees. Why this happens? Because the thermostat has set to 104 degrees and the baby sometimes shivers. So historically, we used to say whenever a baby having fever is shivering, it is either malaria or UTI. It's not like that. Any viral infection can also have a fever of 104 degrees. So the body shivers. With the rigor, they increase the body temperature, and the body temperature, once it is, they reach 105 degrees, then the shivering comes down. So it is a very important, that most important cause of fever in children is, of course, infections, but we have certain other things like inflammatory conditions, leukemia, malignancies also can cause this. So the common causes of fever in children are the viral and bacterial infections. You might have commonly the upper respiratory tract infection like common cold, ear infections. You may have more common is an urinary tract infection, especially in younger children, in infants. A little older child also may have sinus infections, throat infections. And of course, to name a few, flu is very common, pneumonia, dehydration, gastroenteritis, anything. So other than this, you may have some prolonged fever causes like typhoid fever, brucellosis, and some inflammatory conditions which we are mentioning. So we are not, today our topic of discussion is not to discuss on the common causes of fever. So I'm just cartling on that. And the importance of managing fever is very, very important. Why we should manage fever? Alleviate the discomfort and improve overall well-being of the child. It prevents the complications associated with high fever and promotes adequate hydration and rest. And very, very important is the parents' anxiety is also alleviated if we can come down on the fever. So important of antipyretics lies in that the principal benefit of the antipyretic drug is to make children more comfortable and to relieve the parents from the anxiety. This is very, very important. Antipyretics do not treat the underlying cause of the fever, but it provides a symptomatic relief. Appropriate use of antipyretic is crucial aspect of fever management in children. Now, what are the commonly used antipyretics we use? It's always all right for paracetamol, ibuprofen, sometimes, but not usually. Aspirin is is not used in children due to high risk of Ray's syndrome. So this paracetamol is one of the most common antibiotic drug used for the management of fever in pediatric patient. It is a very safe. The safety profile is very high. So according to national and international guidelines and recommendation, paracetamol has been considered as the first line choice for the treatment of fever and also has been included in the list of essential medicines for children by WHO. So paracetamol is typically preferred over ibuprofen because ibuprofen has some of the side effects which we don't want in children. Like it can reduce the protective effect of the prostaglandins in the stomach, and if used for prolonged periods may result in gastritis, and it may be sometimes dangerous in children having some of the infection causes thrombocytopenia, like very common all over India is dengue. So the season is coming for dengue infection. So in that case, when you have a low platelet count, it is sometimes very dangerous to use ibuprofen. But paracetamol has a very well. So this is the difference in paracetamol and ibuprofen. For a feverish child, you know, the dosing interval is less for paracetamol and it's more for ibuprofen. Usually ibuprofen is given not more than 3 to 4 times in a day, whereas paracetamol can be given 4 to 6 hourly, depending upon the dose. See, for paracetamol, we have to see the accumulative dose should not be more than 60 mg per kg per day. So if we are giving it 4 hourly, that is 6 times per day, so the per dose should be around 10 mg per kg per day. But if we are giving 15 mg per kg per day, the highest possible dose of paracetamol, then the dosing interval should be around 6 hours. Because if you give 50, if you multiply 15 into 4, if you're giving it for 4 times, it becomes 60 mg per kg. So both are equally effective. Maybe sometimes ibuprofen has a higher edge, it is much more effective, but safety profile is much higher in paracetamol. It is preferred in children with GI infections, as I said, in any condition where there is a risk of bleeding. So suppose a pre-existing gastritis is there, GI like typhoid, like dengue, as I said before. So ibuprofen has a risk of gastrointestinal irritation and mainly gastritis, and it may lead to bleed in the GI tract. So paracetamol is preferred in patients at high risk of GI bleeding, and it is preferred in children with any other diseases like chickenpox. I would also like to mention especially dengue, because ibuprofen has a risk of severe cutaneous complication in patients with varicella or herpes zoster. And also, as I mentioned, in dengue, they have a high risk of GI bleed. Paracetamol is preferred over ibuprofen when there we think of renal toxicity. Okay, it is preferred in children who are dehydrated or with a pre-existing renal disease or multi-organ failure. So even IV paracetamol is very well available nowadays, and in a very sick babies, rather than to give other things, you should go for IV paracetamol. So mechanism of action is paracetamol works primarily by inhibiting the production of prostaglandins in the central nervous system, specifically in the hypothalamus. It has play a role in regulating body temperature. So by reducing the levels of prostaglandins, paracetamol helps to lower the fever and alleviate the associated symptoms. It is important to note that paracetamol does not directly address the underlying cause of the fever, be it paracetamol, be it any antibiotic. So you have to make necessary arrangement to lower the cause of the fever. Suppose if it is a typhoid, if it is an antimalarial, give antibiotic appropriate, give antimalarial appropriate. Of course, for the viral fever, you don't have any other options other than giving the antibiotic. So paracetamol mainly gives a symptomatic relief, which is very essential in most of the fevers. Furthermore, since there is no significant inhibition of prostaglandin outside the CNS, it doesn't have any associated side effects. So it is mainly working on the prostaglandin produced in the brain. So, and thus it is decreasing the fever. Okay. So it is not associated with other side effects. They are seen with aspirin, ibuprofen, and other NSAIDs such as platelet dysfunction and GI bleeding. So recommended dose, as I mentioned, it is 10 to 15 mg per kg per day. So if we have a high grade of fever, it is usually the response to 15 mg rather than 10 mg. But if you are giving 15 mg per kg per day dose, it is, it will be 15 mg per kg per dose. Okay. So the cumulative dose should be 60 mg per kg per day. There is a, there's a printing mistake. So it will be 10 to 15 mg per kg per dose is the appropriate dose for treatment of fever. Paracetamol is approved in pediatric patients from birth, including those with dehydration, whereas ibuprofen is not approved for use in children under 3 months of age and is contraindicated in patients with chickenpox, dengue, and in those with dehydration where there is a renal toxicities and sometimes with severe pneumonia. So the recommended doses and frequency of administration of paracetamol, if we have a 125 mg per 5 ml, I would like to mention now many of the paracetamol syrups have 120 mg instead of 125 mg. So we have to take care of that. Age-wise dose of paracetamol syrup it is given as a just here, but it's always better to calculate according to the weight of the baby, because you know a 6 months baby can be 5 kg, 5.5 kg old, or weight, or it may weigh around 8 kg. So it is always better to calculate the dose according to the weight. Now the drops will have 100 mg per 1 ml. And the syrups will have 120 or 125 mg per 5 ml. So if you are using drops instead of syrup, you have to be very cautious and please explain it to the parents very well. So whether you are giving drops, and the dose of syrups cannot be given in dose if they are using drops. Okay, suppose you have written 2.5 ml. So instead of syrup, they are giving 2.5 ml of drops. It will be very high dose. So that you have to always be cautious of. It is not recommended in children weighing less than 2 kg, but this is official, maybe unofficially we use it. So maximum 4 doses in 24 hours with a gap of at least 4 to 6 hours between 2 doses is the recommended dose. So again, I will highlight on this. So if you are giving 15 mg per kg per dose, 4 doses means become 60 mg. You cannot give more than 4 doses, because then the cumulative dose per day becomes 60 mg per kg per day. So any side effect of paracetamol, the common side effect is liver toxicity, can occur only if you are giving above 60 mg per kg per day. But if you are giving a lower dose of 10 mg per kg per day, you can give it 6 times. So safety profile of paracetamol, it is generally considered as very safe and well tolerated when used at recommended doses. So never exceed the dose of paracetamol. It has been extensively studied and used for many years in the pediatric population. Adverse effects are rare when the medication is used appropriately. So whatever side effects we have seen, it's only seen when we are using it in more than 60 mg per kg per day dose. Very rarely, I have seen one case who was allergic to paracetamol. It's a very rare case that may occur, but otherwise it is very safe drug. So important safety tips is to ensure the safe use of paracetamol in children. It is crucial to follow these safety tips. Always use appropriate measuring device. Like don't tell them always to measure it with the cap given, never with a teaspoon. Don't write 1 teaspoon, 2 teaspoon, because the size of the teaspoon may differ. Okay, so always measure it with the cap, or if you're using drops, with the markings in the dropper. So such as oral syringes or dosing cups. So if they are not that much confident, you can use oral syringes. Suppose 1.25 is very difficult to measure in cups also, the cup provided by the syrups. So you can tell them to use a 2 ml syringe and show them exactly this is 1, this is 1.5 ml. So to ensure accurate dosing, you should use devices like oral syringes, dosing cups. Do not exceed the recommended maximum daily dose of paracetamol. Educate parents and key caregivers about the importance of reading and following product labels and instructions. And very important, sometimes you will see even after giving paracetamol, the fever is not coming down. So very important, teach the parents to hydrate the baby, to do sponging along with paracetamol if there is a very high fever. So to conclude, among the various available antipyretics, paracetamol is a widely used antipyretics in children. It is very effectively reduces fever and provides relief from associated symptoms. But always remember, this is giving a symptomatic relief. The underlying disorder has to be treated. If it is viral, fine, it will come down. But if it is something like malaria, typhoid, these autoinflammatory disorders, rheumatological disorders, you have to treat the underlying cause. When used as a recommended dose, it has a favorable safety profile. However, it is important to be mindful to the potential risk of liver toxicity. As I mentioned, we recently got a child who got admitted. The child was getting around 100 mg per kg per day of paracetamol every day and was having a fever, prolonged fever for more than 8 days. The child came with a liver toxicity. So you have to be potential risk of liver toxicity is only excessive doses are taken. It is very, very safe drug when given in a perfect dose. So adhering to proper dosing guidelines, monitoring for adverse effects, and seeking medical advice when needed ensure the safe use of paracetamol in children. So I think I'm open for the questions. So if you have any questions, you can ask.
Thank you, ma'am, for a very insightful presentation. Your insights and perspectives on this topic were really very encouraging. So, particularly the part where you have talked about the dosing of paracetamol, and being a pediatrician myself, I know very well that the dosing of paracetamol is very important because it's a very, very safe drug. But you should never exceed the dose of paracetamol, which is the time when it can become a little problematic. Otherwise, it's one of the safest drugs that we use in children. So, ma'am, there is a question where Dr. Agrawal is asking, fever persisting despite injection diclofenac, what to do after that? Probably what I feel what he's trying to ask is that suppose in cases of hyperpyrexia,
Yes.
when after paracetamol, we have tried, say, for example, diclofenac, and intramuscular diclofenac has been given, painful condition, fever also there. So is there any other sequence, if you can tell me the sequence in which the antipyretics are used?
Yes, basically, if the child is sick, often the oral paracetamol, maybe due to the absorbability problem, doesn't work. But we have, truly speaking, I work in ICU only. So we have seen very good results with IV paracetamol or even with the parenteral paracetamol. So I would always suggest to use a parenteral use of paracetamol is also very, very safe, provided that you are giving in the correct dose. So you can go for it. And sometimes if it's a autoinflammatory or rheumatological related problems, they don't respond. So you have to find out the cause for it, and they really do good with the NSAIDs, the other NSAIDs. Okay. So in that case, sometimes you have to go for naproxen also. So we have used naproxen also in some of the cases like this. So you can go for naproxen, but if they respond to naproxen and not responding to paracetamol and other NSAIDs, you have to find out it must be some rheumatological disorders, JIA or SOGIA, because sometimes they're present in a very, not a very typical way. They may not present with a typical arthritis and rash, but there may be some of the pointers. You will find out there is a high CRP, there is a neutrophilic leukocytosis, and after a few days, they present with joint pain and so usually the infectious cause of the fever, they respond. But if they are not responding and you are needing higher generations, higher things like naproxen, you have to find out the cause of rheumatological and other autoinflammatory disorders. So that you have to work on.
The risk of Ray's syndrome and all are also considerably reduced when we are using safe drugs like paracetamol.
Yes, absolutely. Ray's syndrome is actually, we have heard in the literature, and we have, because from the my PG post-graduation still now, we have not seen much, because the use of aspirin has been totally stopped for this after chickenpox and all those things. So I think because of the awareness that it can cause Ray's syndrome, people don't use. I have seen even after chickenpox vaccine, giving chickenpox vaccine, people write, don't use aspirin. So I think that is the reason why Ray's syndrome. We do see very, very rarely, but so it's always better to play safe with children, and paracetamol is the drug.
So, ma'am, you suggest paracetamol to be the first line drug. We all know that as pediatricians, paracetamol is definitely the first line drug. After that, you have suggested naproxen. What about IV?
Naproxen is only if it's not responding.
Yes.
See, if it's not responding to paracetamol, though ibuprofen we try to avoid, but we sometimes give in high fever. And if it's not responding and you are sure no infectious cause, you are also treating the underlying cause, but it's not getting healed, you have to have a workup for rheumatological. And if you have a slightest hint, start naproxen, it works very well.
Okay, ma'am. Ma'am, there is a question.
Mefenamic acid people use. I would like to highlight one thing also. So mefenamic, we always try to avoid that, but you can go if
The
you.
gastritis part is in my patients. I've seen the gastritis part with mefenamic acid is considerably higher than much safer drugs like paracetamol. We have seen you often need to give antacids or antiemetics when mefenamic acid is used.
Absolutely. So these have so many side effects. So it's better to
And there
avoid.
is a question where they're asking that WHO has mentioned there is less evidence for contraindicating use of NSAIDs. You probably talked about NSAIDs in dengue fever. So they are asking use of NSAIDs in dengue fever and therefore suggestions should be reconsidered. What are your perspective on this?
So the main reason why we avoid NSAIDs in dengue fever is initially, even if the platelet count seems to be normal, there is a means suddenly it can fall. And we have seen severe GI hemorrhage. So other NSAIDs other than paracetamol, not only they can cause also platelet function disturbance. So in a condition where you suspect there may be thrombocytopenia at any moment, and if you are using a drug which has moreover have a platelet dysfunction, so it's always so what I do on this is our ICH is a very premium institute in Eastern India. So in none of the consultant, we just don't use any ibuprofen in the monsoon season if the patient comes with fever, because you don't know, the dengue will not always come in a very classical way. So it's always better to avoid. That's.
Ma'am, plus you have also very nicely outlined the precautions, especially when you're using drops versus suspensions for paracetamol, because obviously the dosage is different. The strength of the suspensions is usually 120 or 125 milligram 5 ml, while in drops it is 100 milligram. So I mean, a question is they just want you to repeat the cautions that need to be used in such cases.
Because I highlighted that only because we are seeing, so the consultant has written in the OPD prescription a syrup, but the child may be around 9 months, 10 months old. So the parents were using the drops before. What they do now, they are using, because thoda bahut drop bacha hua hai, so they are using that drops and giving in the concentration of the syrup. So it's causes serious side effects. So that we should always mention that drops are very highly concentrated and the syrups are different dosing. So whenever you're changing from drop to syrups, that we usually do around 1 year, we the pediatricians have to reinforce it that the mother understands the difference between the drops and the syrup. This is very, very important.
It needs to be very clearly outlined on the prescription itself.
Yeah.
I mean, we follow this that whenever we are prescribing drops of syrup, we specifically write the strength as well. So that chemist also does not have any problems in giving the correct formulation in such cases. Man, just two more questions. Can you tell us about the combinations, the fixed dose combinations? I understand they're not very rational combinations, but there are many fixed dose combinations of different antipyretics that are available in the market. How safe are they and what is your take on them?
See, in general, any drugs with a fixed dose combination should be banned. It's my personal view. Okay, so be it antipyretics, be it cold cough medications, be it antibiotics especially, okay? Because if you are, see, some of them has overlying functions. So when you are combining them, it gets exaggerated. The side effects gets exaggerated. This is a very important thing. Second thing is sometimes you are using the associated thing without any use. Suppose I want to use ampicillin just for an example. So why I will give Ampiclox? It's like that. So suppose I want to use ibuprofen. So why I will give a ibuprofen plus paracetamol combination? See, it's always best to have separate combinations, separate drugs. So if you're wanting to use two drugs separately. Because fixed dose combination, one problem is sometimes we are using the other drug which has no function. Sometimes we are exaggerating the side effect because we are combining the two. Third important is sometimes very important is the dose schedule. Suppose you have a combination in a dose schedule
Yes,
and
ma'am.
which is a fixed drug combination schedule. Na? So now you want to give, suppose I want to give something, a lesser dose, that you cannot do with a combination drug. So these are very important adverse, or should I say disadvantages of combination therapy, whatever form it is, and should be discouraged. This is my personal, and I think our institute, we always do. If using combination drug, we always try to avoid combination drugs.
I resonate your opinion, ma'am, because we have seen, plus I personally feel the different drugs, their frequencies also are sometimes different. For example, mefenamic acid, we use 12 hourly, while paracetamol, we often use 4 to 6 hourly. So
Absolutely,
I mean, the
yes.
combination
Again, the
absolutely
dose
does not have
duration
any
also.
rational, does not have any rational.
You will see very common is ofloxacin, metronidazole. So
Exactly.
ofloxacin used twice, metrogyl is needed thrice. So if you give ofloxacin metrogyl combination, which is a very rampantly used, how can you how can you assure that it will have a very good drug level? So this is not. And of course, for ibugesic paracetamol, the same works here. So you cannot give 8 hours, it's 8 hourly for paracetamol. It's better to give 4 to 6 hourly. So if you're using an ibugesic paracetamol combination, so you have to give it 8 hourly. And so the paracetamol portion is not working that well. So that you have to take in consider.
So I think these were the questions, ma'am. Thank you very much for sharing your thoughts and your experience in this topic, especially the part where you discuss so nicely about the prescriptions for drops and syrups and why we need to be very careful. Otherwise, I think take-home points is paracetamol is one of the best drugs, one of the safest drugs to be used in children. Safety is of primary concern when we use any drug in children. And the take-home point, I think, is that paracetamol needs to be used for all types of fever in children, and move on to the second antibiotic only when, in those rare cases where the child is not responding to the frontline antibiotic.
Absolutely. I would just end with one sentence. It is the safest drug. The vitamins, most of our prescriptions in our OPD, in this premium institute, consist of only paracetamol and some vitamin drops in most of the fevers. So we would like to, so we really need anything else. So counseling is very, very important. So do counsel the parents, because fever is not, it's a symptom. It's not a disease. So you have to counsel the patient just and give only paracetamol, so that in this way we can keep our children at a safety level. Okay, thank you.
Thank you very much, ma'am. It was a pleasure to have you with us.
And I'm extremely sorry for the delay. Okay.
No problem at all. Thank you very much, ma'am. Thanks a lot.
Okay, thank you. Thank you.
So we now move on to our second presentation of the day. So this presentation will be on fever not responding to. So we were discussing with Dr. Kia about the part where paracetamol needs to be used first, but in case it does not respond to the frontline antibiotics, we need to obviously then move on to the second line antibiotics. And for discussing on this point, on this topic, we have Dr. Balasubramaniam, a very, very well-known pediatrician from Chennai with us. And he will be sharing his views, his thoughts, his experiences on this topic. So over to you, sir. Please share your views on this topic, sir.
Thank you, Dr. Pankaj. Let me share the screen. Yeah.
Sure, sir.
Yeah, is my screen visible? My audio is okay?
Yes, sir. You are visible, sir.
Okay. Thank you. Thank you, Dr. Pankaj. The topic in focus now is fever control and frontline antibiotics. The purpose of this session is to discuss the causes, the correct method of evaluation and management of fever that apparently does not respond to, I would want to add, apparently does not respond to frontline antibiotic medication. Why should we control fever? It's $1 million question. In fact, there is always a debate in medical literature. Is fever a friend or foe? In fact, animal experiments suggest that, once the temperature goes up to some extent, it does good to the host by killing microorganisms, by moving WBCs to the site of infection. It helps the host. But at the same time, once the temperature is very high, say 40 degrees, 39 degrees. It is proven with animal experiments that the immune system, as well as the homeostatic system, gets imbalanced. But let us forget those physiological aspects. To the mother and the father, the child having fever has a lot of discomfort. Basically, we have all taken the Hippocratic oath to alleviate discomfort and to promote patient comfort. So that is one of the reasons why we should treat fever. And we should also try to reduce the risk of complications whenever there is a long duration fever. And the complications sometimes may be because of the medications or maybe because of the illness. Both have to be prevented. And more importantly, the child should take enough rest and should be hydrated well. For every degree rise in temperature, centigrade rise, the insensible losses go up by around 12.5%. Your requirement goes up. So you have to keep the child hydrated. Paracetamol, paracetamol, paracetamol. I mean, it continues to remain the number one antipyretic. One must be wondering why. Basically, it's a very safe drug. But in pharmacopoeia, one of the safest medicines is paracetamol or acetaminophen. It has got an extremely wide therapeutic window. Conveniently, it acts only for a short period of time. You can repeat it every 4 or 6 hours. And as mentioned by my earlier speaker, hypersensitivity is very rare, but it can occur. Allergy, urticaria, anaphylaxis has all been reported, but it's very, very rare when compared to all other agents given for fever. And very importantly, even in those with liver disease, somebody with hepatocellular failure, acute or chronic, somebody with cirrhosis of liver, somebody with chronic liver disease, you can give paracetamol for fever. I mean, there is a concept amongst physicians that if you have jaundice, if you have hepatitis, you should not give paracetamol. You can give paracetamol. You can give the usual therapeutic dose. No harm will be done. On the other hand, drugs like NSAID, they are more dangerous in liver disease, not paracetamol. Majority of children who receive acetaminophen or paracetamol respond with the decrease in temperature, usually in about 30 to 60 minutes, perhaps earlier than that also. It's rapidly active. The other greatest advantage is that you can give paracetamol frequently, every 4 hours you can give. And fever has a tendency, particularly when it is due to viral infection, to come back with a bang in another 4 to 6 hours. The child may get distressed. You can control the fever with a repeat dose at 4 hours. This is one of the reasons why paracetamol continues to remain the first drug, first choice antipyretic. Ibuprofen has been approved as an antipyretic for fever above the age of 6 months. However, ibuprofen is an NSAID. It can lead to erosive gastritis, GI bleeding, ulceration of the esophagus as well as the stomach or duodenum, even in therapeutic doses. But our mothers have a tendency to think that Langanam is Parama Aushadam. That is, starvation is the best drug. That is the concept most mothers have. So when a child has developed fever, mothers have a tendency to feed children less. That increases the risk of GI side effects due to ibuprofen, which can cause, and these side effects include dyspepsia, nausea, vomiting, pain, and GI bleeding, perforation. Nimesulide, which was once available for use, has been banned and withdrawn because of the notorious side effects on the kidney and the GI tract. Because of all this, paracetamol is the number one antipyretic. It is preferred over NSAIDs. There are some situations when you give the frontline antipyretic, paracetamol or sometimes even ibuprofen, there is poor response. And even before the next pharmacological dose, the fever climbs up again. This causes a lot of parental panic and anxiety, other than causing discomfort. And there is a term which is used called refractory fever, where you give a frontline antibiotic, within 4 hours it doesn't respond, the child has discomfort. What do you do in such a situation? You must remember, this is a situation where the skills of a physician's counseling abilities are put to test. The most important thing he must attend to is the hydration. Increase the fluid intake. Because during the febrile process, dehydration occurs. And once you give an antipyretic, it causes more insensitive losses due to peripheral vasodilatation and evaporation of water and solutes. So you should relieve the discomfort, you should hydrate well, and you should bring down the temperature. How do you do it? How do you approach such a situation? Of course, you must always identify and treat the underlying cause. It's easier said than done. Most of the time, you don't know the cause for fever. Most of the time, the fever is viral, for which no specific treatment may be available. Or sometimes you may have a specific disease like malaria, UTI, you can treat. Coming to the antipyretic options, what are the options available? One is you can add an alternative antipyretic. For example, you give paracetamol, you give ibuprofen for the next dose. In fact, various studies have shown whether it is a single drug or combination, that is acetaminophen and ibuprofen alternating doses, the effect on fever is nearly the same. So there is no rationale in combining acetaminophen with ibuprofen. The most important thing you must do when there is a refractory fever is to check the dosage. Those dosage should be checked. You must remember the ideal dose of paracetamol is 15 milligram per kg. And it can be repeated every 4 hours. But however, we should not exceed more than 5 doses per day or a maximum of 75 milligram per kg per day. This has to be counseled. This has to be counseled to the parents, stressing that please do not keep on giving paracetamol. And we must also stress that the correct preparation of paracetamol should be given. They should not change from drops to syrup, syrup to drops, and get confused and give wrong dosage, which can end up in paracetamol toxicity. Of course, physical methods of cooling have been traditionally used to bring down body temperature. I'm not a great proponent of tepid sponging. You must be wondering why. Tepid sponging may look like something which is very easy to do, which is harmless, and which may be effective. But I'm afraid the correct technique of tepid sponging is not often followed. What do you mean by correct technique of tepid sponging? But if you want tepid sponging to be effective, the tepid sponging has to be done about 15 to 30 minutes after administering paracetamol or an antipyretic. You should not do tepid sponging at the height of fever before the fever starts coming down. You know, we all know that the fever has got hot stage, cold stage, and you should give it when the fever is coming down, when there is vasodilatation. The fever is at its peak and there is vasoconstriction. If you do tepid sponging, the child may feel more uncomfortable and start having rigors. That is one. Second is tepid sponging. You should not use water which is from the refrigerator. Should ideally it should be 28 to 30 degrees. That is the temperature. It depends on the environmental temperature. The tap water temperature will vary. Ice water should not be used. And tepid sponging is a laborious technique. You must have, sponges kept in the armpit, kept in the groin. It should be done for about 15 to 30 minutes. It's technically a difficult procedure. The physician who believes in tepid sponging should know everything about the correct technique of tepid sponging, demonstrate to the mother, then only advise tepid sponging. Most nursing councils across the world have given up tepid sponging as a method of bringing down temperature. So we should depend on antipyretics rather than tepid sponging. Coming to the therapeutic approach, you should individualize the approach. And you should try to bring down fever with the safest medication, that is paracetamol. Very important to counsel the parents. What should you counsel? You must only tell them fever is only a symptom. Fever by itself is never going to kill anybody. The cause for the fever may be fatal, not the fever per se. Of course, fever increases the risk of febrile seizures, fever increases the risk of metabolic acidosis, fever increases the risk of dehydration, fever increases the risk of decompensations, various compensated diseases of the heart, respiratory system, etc. But by and large, fever per se is not by itself a dangerous symptom. We must counsel the parents about the warning signs in fever rather than frighten them about fever. We should tell them paracetamol is the best known antipyretic. We must counsel them about the correct dosage when to give. And we should tell them even a safe drug like paracetamol is not to treat the temperature chart numbers of 102, 103. It is to treat the child's discomfort rather than treat the number. To conclude, fever control, which doesn't respond to frontline antipyretics straight away, it is a challenge in patient management, and it's a test of skills for a family physician or a pediatrician who has to counsel a lot. Understanding the causes, conducting a thorough evaluation, and implementing appropriate management strategies are very, very important in such cases. We must always address the specific cause for fever. If required, add-on antipyretic may be used judiciously. Tepid sponging, if the technique is correct, we can use, otherwise need not be given routinely. By taking a comprehensive and individualized approach, all healthcare providers can effectively and safely manage fever resistance and ensure that their patients are well. I'm willing to take up any questions. Thank you very much.
Sir, thank you for a very engaging presentation. Your experiences, very noteworthy points that you have informed us about fever, which is not responding to the frontline antipyretics. So there is a question where they're asking, is it really important to treat fever? For example, we all know febrile seizures occur in children less than 5 years. So there is a definitive advantage of treating fever. But in case fever is a body's mechanism, a thermostat mechanism to counteract infections, is it really helpful to treat fever in children above 5 years of age?
Even below 5 years of age, there is no data that treatment of fever with antipyretics or with any measures reduce the risk of febrile seizures. Aggressive antipyretic therapy does not reduce the risk of febrile seizures. We must understand the pathogenesis of febrile seizures. Febrile seizures usually occurs when the temperature goes up suddenly. And most febrile seizures occur within about 2 to 4 hours of the onset of fever. Most febrile seizures occur even before the mother recognizes there is fever in the child. In fact, they have done studies. They have even given diclofenac suppositories for fever, trying to prevent febrile seizure. It does not work. So if anybody thinks that by giving paracetamol or ibuprofen, you can prevent febrile seizure, the idea is absolutely wrong. But one of the things I counsel in my practice, when I meet parents whose children have febrile seizure, I tell them, science does not know how to prevent febrile seizures using antipyretics. It doesn't work. I tell them very honestly. That's a very honest answer. Whether it is below 5 years or above 5 years, fever should be treated only for alleviating discomfort rather than of the child rather than the mother or the father. Okay, if the child is playing, even if the temperature is 39, you shouldn't be worried, particularly in older children. But definitely young children, when the temperature crosses 102, they definitely have discomfort. Antipyretics would definitely relieve the symptom, but it's not going to cure the disease. So the most important thing is for the physician to counsel the parents that fever is only a symptom, not a disease by itself.
Truly said, sir. Correctly said, sir. So there is also a question on antipyretics where they are asking, is there any discrepancy between the maximum doses? Why is there a discrepancy between the maximum doses 60 to 75 milligrams per kg per day? Most likely they're asking for paracetamol. So are there
Paracetamol up to 75 milligram per kg is okay. More than 100 milligram per kg can definitely be toxic. In fact, there are some disturbing reports from Singapore where they publish even 10 milligram per kg of paracetamol 4 times a day had caused hepatocellular failure in dengue. So, by and large, up to 75 milligram per kg paracetamol should be safe.
Okay, sir.
But then I don't know, why should we give 5 doses per day? There is no need. Just because the mother is seeing a temperature chart, we must look at the cause for the fever and worry about the cause for fever than about 101, 102. Child is playing, I wouldn't give paracetamol at all. I'll tell them it causes discomfort, you give. Don't exceed maximum of 5 doses, that's all.
Exactly. So, sir, there is another question. This question is directed to Dr. Kia. Because since she mentioned about mefenamic acid, so they're asking about the dosages of mefenamic acid, the safety concerns, if any, related to mefenamic acid, especially vis-a-vis to paracetamol.
I don't know the dose of mefenamic acid because I don't use it. I don't recommend. I oppose use of mefenamic acid. I don't use mefenamic acid. In fact, I wrote a letter to the Indian Pediatrics, the Indian Pediatrics Journal. I saw an advertisement for mefenamic acid in the journal, and I strongly criticized that, and I wrote to them about the side effects of mefenamic acid and the need to stop using it for fever. I don't use mefenamic acid. Mefenamic acid is not a good drug at all. It can cause renal failure, it can cause erosive gastritis, it can cause hematuria, it can cause perforation. It's not a safe drug. And I don't know why pediatricians like the drug. I don't like the drug.
Ma'am, your take on this?
Absolutely. I will agree with Dr. Bala, sir. Absolutely. I also never use mefenamic acid, but I have seen a patient coming with, they are having mefenamic acid and they are asking why not, because this is causing a quick of the fever. So why, doctor, you don't give? So I just only explain because for me, the safety of the children is much more important than making them the fever to come down. So I will agree with Dr. Bala, if the fever is not causing any harm to baby is absolutely playing very well, then why we are after treating the fever? So we also always counsel like this. So just don't go after the fever, just you have to come make the fever should come down. You don't at all think at all like this. You just think whether the baby is comfortable or not and use a drug which has a safety profile. So I don't use usually mefenamic acid, but I think the dose is around 5 to 7. I'm not very sure. I have to check it.
Around, say, yes, 7 to 8
So
milligrams per kg.
personally, I've never used mefenamic acid. And also, as I said, ibuprofen very rarely. And naproxen we use only if we think of any rheumatological disorders. So other than this, we don't use any other antipyretics in our practice.
There is a question in the case of combination antipyretics. For example, we have combinations of paracetamol and ibuprofen available. Are there any new considerations to be taken into effect when we are giving antipyretics? Should we ensure safety in a different way, or should it be precautions for both paracetamol and ibuprofen individually? I mean, what is better, taking them individually or taking them in combination?
Only in India, this combination is available. It should be banned. They have banned so many other things. Ibuprofen, paracetamol, mefenamic acid, paracetamol
Yes.
should be banned. There's no place. It's unscientific. The half-lives are different. You can't give the correct dosage. There is no rationale at all. This combination has not been proven to be of value. Nobody should be using it. Strong words, but that's science.
So, sir, this brings me to another question. Ma'am, you can please put your views on this. So, we were talking about fever not responding to a frontline antipyretic like paracetamol. So, in case there is a child who has a fever, antipyretic paracetamol has been given around 3 to 4 hours later, the fever does not respond. So, would it be wiser to use another dose, since we are already 4 hours past the first dose, to use another dose of paracetamol or move on to a second drug, let's say ibuprofen?
So if it is more than 4 hours, always try to repeat paracetamol. And what I say, if the fever is not coming down, as Dr. Balas has said, tepid sponging should be encouraged when the fever is coming down. So give paracetamol initially. And if by 1.5 to 2 hours, the fever is not coming down, you can go for tepid sponging. Usually that makes the fever comes down. So by repeated tepid sponging with normal water, not with cold water, as specifically Sir has mentioned. And so if 4 hours is gone, you can always repeat another paracetamol. So, but cumulative dose, you have to see that it should not exceed, as Sir said, it is 75, but I usually try to maintain 60 to 70, 60 mg per kg per dose per day. That should be that cutoff. So we explain the parents like that the total cumulative dose. So if you are using 4 hourly for 2 to 3 dose, make sure the 4th dose and the 5th dose is given at a longer interval, so that the cumulative total doses in throughout the day should not cross more than five doses. So you can make them. So counseling is very important. How you counsel them, it's very important.
So your views on this?
No, very simple. See, I don't worry about 103, 104 if it is not coming down with paracetamol. But I give a temperature chart in my clinic, which contains warning signs. I tell them, don't worry about the temperature chart. If any of the warning signs like drowsiness, when there is no fever, decreased activity, decreased urination, tachypnea, seizures, lethargy, rash, you go to the emergency room and get hospitalized. I don't give stress to repeating doses. But in my temperature chart and my instructions on antipyretics, I tell them not to give more than 5 doses, not to repeat it at more than 4 hour interval. That's all. So within 4 hours, if it is not coming down, I wouldn't worry much. If the child is otherwise all right, I wouldn't worry about the temperature at all. I bring down the anxiety of the parent rather than try to bring down the fever, which I know I'm not going to bring down. If it is going to be dengue, day 1, day 2, 103, 104, there's no way I can make the child completely afebrile. So I tell them there's no point in worrying. I counsel rather than, try another antipyretic, change the drug. It doesn't seem to work. Only counseling will work.
Point well taken, sir. One more question, sir. Sponging, tepid sponging, is it an acceptable part of treatment as per the guidelines, sir? I mean, we all do it, but is it acceptable?
No,
sir?
as per the guidelines, tepid sponging has gone out. You can go to the NHS NICE guidelines. Tepid sponging is not recommended. You can go to the various nursing council recommendations for fever. Tepid sponging is not there. It is not recommended. It's not recommended. There is a good Cochrane review also saying that tepid sponging is not likely to be helpful.
Okay, sir.
It doesn't add to the with the comfort of the child.
So there is a question, dosage of mefenamic acid is 4 to 6.5 milligrams per kg per dose, which doesn't cause any major side effects. So again, we have come back to mefenamic acid. So is it like we can still use it because it doesn't cause any major side effects?
We should not be using mefenamic acid in children. Very clear message. Please, whoever has asked the question, please stop using mefenamic acid. Okay, continue to rely on paracetamol. If you are fond of ibuprofen as an alternative drug during non-dengue seasons, older children, yes, you can use ibuprofen. That's my humble opinion.
So I think point well taken. I think we are through with all the questions, sir. So I thank Dr. Balasubramaniam and Dr. Kia for sharing their expertise with us. Thank you, both of you. It was a pleasure to have you with us, sharing your experiences on these drugs. Thank you very much.
Thank you.
And for the participants, thank you. With these two presentations, we culminate today's event. On the behalf of Academy of Medical Excellence, Apex Laboratories and Pasi Healthcom, we thank you for joining today's event. And it was a pleasure hosting you all. And we wish to see you again in the second webinar a few months later. So thank you very much. Thank you, sir. Thank you, ma'am. And goodbye.
Thank you very much.